The information shared on the Allo podcast is not intended as medical advice. Your medical care decisions should be made in consultation with your physician who is familiar with your specific case.
Hi, welcome to the Allo podcast by the Allo Hope Foundation. I'm Bethany Weathersby.
And I'm Molly Sherwood. And I'm just getting back into my work vibes, just getting into the swing of work life after doing, mom life things.
Mom stuff. What kind of mom stuff have you been doing lately?
Well, a lot of cleaning, mostly cleaning, but especially puke. It's like a classic for us. We're driving to school. And the drive to our school, we go to like a farm. Like my kids go to a pretty rural school, so it's like 25 minutes. And my middle son, Hayes, has like a juice chugging problem where he can't just sip his juice. Like it's not possible for him. And so I was like, I know this about him. So I gave him just, like a quarter cup of orange juice. And then we're driving and then the roads are windy, and he's like, I'm not feeling good. And so I was like, okay, he's looking green. So I was like, okay, just like sit in the passenger seat for the last couple minutes. And then he just immediately like leans over and throws up, but he does it somehow like perfectly between the passenger seat and the center console crack. It's like,
oh my gosh,
everything else was totally tidy, like totally fine. But I did find this like nice little, a good shaped like scrubbing thing that I have that was long enough, and I like got under there. So
wow,
and that was just a quick blip in the morning, and then it was a normal day.
Yeah, it's just a part of your day when you're a mom, right?
Yeah.
Oh my gosh,
very normal. Anyway.
Yeah, actually, Molly sent me a polo. Hopefully everyone knows what that is, but it's just like a video chat app. And she was just being like, yeah, there's vomit right next to me, between the console and my chair. And, anyway, and then
I was like, anyway, I'm going to get myself some Starbucks.
Yeah. She's just paused in her, just letting it cook in the car while you run into you
let it bake a little bit.
You needed some energy to then dive into the cleaning situation.
That's exactly what I needed. Yep, that's what I needed.
Gosh.
Anyway.
Well, my 3-year-old has like really mastered the balance bike. Do you know what a balance bike is?
Oh, they're the best.
It's okay. It's just a little toddler bike with no pedals, but he can go so fast. So lately he will just go out the front door, get on his bike, and then ride off into the sunset in his undies.
Oh, yes.
And he's so fast that I'm like, and I'm old. He's fast and I'm old.
That's a bad combo.
He's faster. I can't get him. And he's like off into the neighborhood. Oh, anyway, so something to look for constantly out the window.
Always on alert.
Okay, let's...
Yeah.
Vomit and escaping toddlers. So,
yes.
Okay,
let's do this. Let's do the work thing now. Okay, today we are so excited because we have a returning guest from season 2 of the podcast, and she is here at the request of many listeners.
And at the request of ourselves, too. Right? Because we really wanted to hang out with her. So it's Dr. Kara Markham, and she's joining us today, and we are so excited to have you here. So welcome.
Hi, I'm excited to be back. Thanks for having me. And I'm glad the second season podcast was received well. So
yes,
it totally was.
Patients loved it.
Good.
Right?
Good.
I think that's the one we got the most feedback on, I think.
Yeah, I think so too.
Yeah.
They love the way you
explain
explain
so excited.
things. Yeah.
Oh,
good.
Yeah.
Mm-hmm.
Right.
I do my best.
Molly and I have been able to actually see Dr. Markham a few times this year at different conferences and things. So we are just becoming friends now, right?
Mm-hmm. That's right.
We like to believe that.
It was
Are we friends?
This last one was the first time I've met I met Molly in person,
I know.
but I've seen you so much on different calls that I didn't realize that, honestly.
Yeah, that was weird.
Old friends from way back.
I know. It was awesome. But we still didn't spend enough time together, I feel like. There was still not enough time. But we're going to see each other again for at least one more conference at the end of the year, I know. So that's going to be great.
Yep.
Oh, yeah.
Definitely.
Yeah, so we're excited because now our listeners can also see you because we're videoing, so that's exciting.
Yeah, we didn't share that piece of
I was wondering if you told her.
But
Bethany, I almost texted you, Bethany, and I was like, did you tell her?
No. I was literally outside hitting tennis balls. Come in, sweaty, red.
Here, do you want me? I'll make my hair.
No, it's okay. This is, I mean, to be fair, this is how my hair usually is. So
there we go. We're just being real.
It's good. It's all
I
good.
thought, oh my gosh, I thought we like talked at length about the camera situation. That must have been someone else.
That's been someone else.
Wow.
For me, it was the microphone situation.
Yeah.
Well, surprise.
Surprise.
Oh my gosh. Wow. I am so sorry, but you look fantastic anyway.
Yes. Yes.
That is a lie.
It's not, no, when we were off camera, what did I literally say to you? You look fantastic.
Oh, that's
Yeah.
true. But
And then we teased Bethany
put
for
on
her
a
hair
little bit of
coif.
makeup, something. Your coif. That's true.
Yeah, I always look like Conan O'Brien, and it's fine. Anyway, okay, we're talking
All right,
a lot.
let's do this.
And we need to, wait, I have one more question that's
okay,
not
yes.
related to the meaningful stuff. Did you ever go to Korea?
I did.
visit?
I was there in June with my
Yeah.
family.
How was it?
It was awesome. Just
Oh my gosh.
amazing people.
Yeah.
Yeah.
That's amazing. One time when we went over there with these friends to visit, and I'm like 5'8" and a half, and my friend Ashley's like 5'11", and so I like tower over most of the Koreans when I'm in Korea. I mean, literally, when I go shopping in a store, they look at me and they say, "No largie, no largie," because they're like, "We don't have anything to fit you. Walk out of our store. You don't need to be here, and you don't need to be advertising our
This
clothes
isn't
on your
for
body."
you. This isn't
No,
for
with
you.
this is not
With
for
a
you. So
physical
literally,
acts of like, please
this
don't.
no
Free
largie,
for you.
and they just like just go, and so so that's me. So imagine my friend who's like 5'11", and one day she had like, it was cold outside, and she had this green like coat on. And then all of the students, these little Korean kids, kept saying a word to her, and she was trying to learn Korean, and she was like, "Oh, what does this mean?" And she was like, "They're saying shilek, shilek. What does it mean?" And then I was like, "They're calling you Shrek. They're calling you Shrek." Because she looked,
no.
they thought she looked like Shrek. And then later we went
sad.
on the subway, totally different group of kids on the subway. They're like, Shrek, Shrek. I mean, everywhere she went the whole day, they thought she looked like Shrek, and it was fantastic.
That is,
Oh my gosh, that's humbling.
Yeah.
yes,
Yeah.
that's a good word for it.
I often felt humbled over there. Okay.
All right.
gonna stop talking
okay.
now, Molly.
We do have a limited time to record this, so we probably need to get into some of the patient questions that we had for Dr. Markham. And quick reminder that Dr. Markham is one of the best MFMs in the country for the treatment of HDFN, and she has seen some very, very sick babies through to wonderful outcomes. And for that, we are so thankful for you.
And also, not just in the country, but in the world, honestly.
Yeah.
One of the best
yeah.
in the world. For real.
But you are, but you are in
let's just
Cincinnati.
dive-
So anyone from the Midwest, lots
yes.
of women from the
Cincinnati.
Midwest go
Come to Cincinnati.
to Cincinnati. That's
We'll
right.
take care of you.
Yeah. Okay, so let's dive into the questions. And quick reminder, again, that Dr. Markham is the expert. Molly and I are we're going to try to be quiet and let Dr. Markham answer the
we're great
questions
at
because
that.
she is the expert. Right. But occasionally we might just share a thought or two along the way. Okay. Okay, let me start with the first question. And thank you to any of the patients who sent in questions for us to ask. This is wonderful. So we'll start with some questions about titers. Here's the question. how frequently do you see antibody titers hitting critical levels if the baby doesn't carry the corresponding antigen? And then how can they actually be that high if it's negative? Did that make sense?
It
Should I
did.
rephrase?
It did.
Okay.
How can they increase even if the baby doesn't have the antigen?
Yes, thank you.
If there's no exposure, why is that happening?
Right.
You know, pregnancy is weird. There's all sorts of physiologic changes. You know, there's changes with the heart, with the lungs, with the musculoskeletal system, and with the immune system. So, you know, the body is kind of working differently to some degree, and I think that probably impacts why these things happen. Just in general, titers will be sufficient to monitor for HDFN in about 50% of patients, meaning that about 50% of women who have antibodies, red blood cell antibodies, will only need titers every 4 weeks and won't ever reach a critical level, need to move on to middle cerebral artery Dopplers or further evaluation or treatment. As for how often you can reach a critical titer when the baby is antigen negative, I don't have a number about that. It's probably not going to be 50% of those patients, but I don't have an exact number to give in terms of how many will end up with a critical titer. But the reason it happens is just related to the immune system being so odd in pregnancy is my guess on that. You're just kind of prone for, primed, I should say, for things to change. And even though the body may not be seeing that exact antigen, it may be seeing other antigens that it recognizes as foreign and kind of ramps itself back up to have a higher titer. But that is a little bit of a educated guess.
Yeah, that's a tricky one. The only time my titer actually rose was when I was not pregnant. It was between, the last 2 pregnancies. And I knew that because I was donating plasma. You know, I'd already been through multiple sensitized pregnancies. It never rose past 1,024. And then suddenly when I'm not pregnant, it goes up to 2,048 and just stays there. So
I like how it sort of seems as if you're talking about it never rose, like you had a titer of 2 or something.
Right.
It never rose above 1,024.
I know. Oh my gosh. I mean, what do you do when you start in the thousands? It's terrible.
But
it sounds like
much higher.
Yeah. But it sounds like it's safe to say, like, I think sometimes in the same vein, people ask, oh, my titer is super low. So does that mean baby doesn't have the antigen, or the other way around? I've even seen some patients, physicians think, oh, because the titer is this, it means the baby is or isn't effective. And it sounds like you're saying
no,
that's not.
I wouldn't rely on titers to tell you about antigen status.
Cool.
Cell-free DNA, that's the way we know antigen status.
Yeah.
Nice.
Yeah. Okay, I have another question also on the titer kind of zone. So another mom asked, how often do you see antibody evanescence, which is where, previously she was positive for an antibody, but then later it comes back completely negative or too low to titer? And is that an indicator of how the pregnancy is going to go if she enters the pregnancy with that type of titer?
We definitely see it. It's, I wouldn't say it's super common, but we definitely see it, maybe 5% of my patients, just as a gestalt. And yes, I mean, if it's one of those titers that is that low and then disappears, it's very reassuring for the pregnancy, because the baby's just not going to get into trouble with that. Now, the question would be in the back of my mind, what if I have a patient who has an affected child, history of an affected fetus or neonate, and comes back without an antibody? I've never seen that happen. And in that case, the argument would be, well, do we even need to do things like middle cerebral arteries? And I don't know the answer to that because I've never seen that happen. We probably would just to be on the safe side. But, and I think if you have a patient with a clinically relevant antibody and they've had it in the past, and they've had it in the past, I would still manage them like I do any patient, even if they have a really low titer, meaning I would do antibody titers every 4 weeks to watch them closely.
Last one about titers, I think. And this is from Instagram. A mom wrote in and said that in her last pregnancy, she had anti-D titers of 2,048. And she asked how risky another pregnancy would be. And of course, you can't predict the future. But she's just wondering, like, would it be super selfish or just like absurd to pursue another pregnancy? And this is a question that we do get from mothers a lot. So what are your thoughts on that?
It's a hard question to answer without knowing more clinical background, such as whether or not she had an affected child. The other question would be, what is her partner's D status? Is he Rh positive? If he's Rh negative, then have all the children you want. If he's Rh positive and known to have D positive, what we call homozygous, so both genes are D positive, then we know the child will be affected and there'll be the risk of HDFN. If he's heterozygous, then there's a 50% chance of being affected. But I don't necessarily think I certainly wouldn't call it selfish. I think with appropriate management, we still would expect to, far more likely than not, help that patient to have a good outcome, even if her child is affected. So, that'd be a patient where you'd want to do cell-free DNA early to determine the baby's D status, if dad's status isn't known, or if he's heterozygous. She'd be a candidate for IVIG, starting before 13 weeks, ideally, with that high of a titer, to try to postpone that first transfusion. And just really close monitoring and intervention as needed.
Okay, and then I have to clarify, she actually said egotistic, not selfish. So
okay,
I don't know how much of a difference there is, but yeah, same idea, I think.
Yeah.
Okay. And I'll just add my piece in. Again, my last pregnancy started at a titer of 2,048, and now he's the healthy 3-year-old who's riding his balance bike down the street and escaping into the
Half
neighborhood.
naked.
So, but it did take a lot of intervention and a lot of work on my doctor's part.
Yeah.
But yeah, he's totally healthy.
I mean, I think that's also part of it, though, is if that patient is emotionally and mentally ready to go through that, because we know it's a lot of anxiety. Depends where she lives. If she's in an area where she has ready access to good care, I think, again, I think it's reasonable. You just have to be prepared for what's potentially going to come, and not just, logistically prepared, but mentally prepared.
Yeah, that's so true. I think a lot of women will really appreciate hearing your sentiment about that, because I think a lot of them feel this worry of, like you said, Bethany, I think the reason the word selfish came to mind is because some women fear that, or some women are told by people around them, why would you try to do this again? Why would you risk this again? And hearing that kind of permission from you, I think, is going to really be meaningful to a lot of people. Yeah.
I can't think of anything less selfish than someone being willing to go through all of that for the sake of another being, right? So, no.
Oh, I love that. Yeah, I love that. Oh, okay. Well, this is a totally random question compared to what we were just talking about.
Switching gears.
Yeah,
Here we
switching
go.
gears. Okay, but it's really interesting, actually. So this person asked, is chiropractic care safe in sensitized pregnancies? Like, I wonder if they're wondering if all that kind of adjusting and moving around could potentially trigger a change in titers or something like that.
The short answer is we don't know. There's going to be no data out there whatsoever. I mean, theoretically, could it cause some sort of maternal fetal hemorrhage that would increase titers, worsen sensitization? Yeah, theoretically it could. But there's no data that tells us it does. I mean, I'd probably err on the side of caution and not recommend it, but that again comes from no data, just erring on the side of caution.
Maybe opt for the prenatal massage instead.
There you go.
Oh yes. Oh yeah. Okay, this is not in the
I think
script.
it also depends on what we're adjusting, right?
Yeah,
if you're
that's
adjusting
true.
your neck, go ahead. That's not going to cause anything. Upper back, sure. It's just when we start getting down to the pelvis that we'd be a little more worried.
This topic reminded me that a couple times we've gotten questions from moms who have a breech baby, and then sometimes they have the option to try that external cephalic version, which is where like the doctor externally tries to maneuver the baby and flip them around. And we know that can potentially it's known as a cause of sensitization, but the question has come up as to whether it's okay to do that in a sensitized pregnancy.
So I think it depends what your plan is to do after the version. A lot of times we talk about if you're trying to vert a baby, you can do it at 37 weeks. It's usually a little technically easier because there's more amniotic fluid, but then you can make an argument, well, we're not going to deliver at 37 weeks. We should wait until 39 weeks. So flip and then wait a couple of weeks. That's not really going to happen in a sensitized pregnancy. I mean, in a sensitized pregnancy, you're probably delivering at 37 to 38 weeks anyways. And if you flip a baby and deliver, that's not going to harm the baby at all, because even if there is a small volume of baby's blood getting into maternal system and causing higher titers, well, the baby's going to be delivered in a day or two, so the baby's not going to become anemic or sick related to that. So I would say yes, it's safe.
Cool. Okay, that's helpful to know.
Right on the way out. Like,
Yeah, exactly.
safe on the way
Flip
out. There
and
you go.
deliver.
There you go. Okay. All right, good to know. Good question, Molly. I'm glad you remembered that, because we had a big discussion in our support group about it, and people had different opinions, so that's good to know. Okay, here's another one. Now we're going to go, since we're sliding on through, let's go to delivery questions.
Okay, delivery question.
All right. So, all
No
right.
pun intended,
So,
just sliding.
Speaking of,
I'm sorry.
Speaking of sliding on through,
Sliding.
A lot of allo-immunized moms are induced. And so there are different options for induction, right? And the question was about, do you think there's a certain type that puts less stress on the baby and on the woman's body, and then they're nervous because the baby is dealing with anemia, so is there a way to limit the stress for the baby in that situation?
So you'll get differing opinions on this. I mean, some people will even argue that particularly women who've needed intrauterine transfusions should have C-sections to minimize the stress on the baby. I don't fall into that camp.
Yeah.
For me, the key is that whatever induction you're doing, you're going to be monitoring the baby's heartbeat throughout. So you'll know if the baby starts to get into distress or starts to become less reassuring, and can intervene by, delivering by C-section if needed, before you let something bad happen. So my standpoint, the method of induction is not, one way is not necessarily better than another. There's all sorts of literature out there with people trying to solve what's the best way to induce a woman, and nothing ever really definitively comes from that. So I would say, the most important thing is that the baby's being monitored throughout the induction process, the labor and delivery process, and that clinicians are there and ready to deliver, however mode that may be based upon fetal status.
Yeah. Okay.
Okay, next one about delivery. How do you decide when to deliver in the situation where a mom does have critical titers, but she doesn't have a history of IUTs?
So there are some kind of expert guidelines out there put together by the American College of Obstetricians and Gynecologists, and probably also Society of Maternal Fetal Medicine, that recommends delivery at 37 to 38 weeks. And that's based on a couple of things. First of all, middle cerebral artery Dopplers aren't as good as you get further along in pregnancy. They're not as predictive of fetal anemia. The truth is they're more likely to be falsely positive. So you're more likely to say that the baby may be anemic and either deliver, or if you're less than a certain gestational age, think about doing a transfusion and the baby's not anemic. But we just think of them as being less accurate when you get later in pregnancy. So if you're taking away some of the power of our primary screening tool for anemia, then delivery starts to become a better option than relying on a test that isn't as accurate. I should say there are 3 reasons. The second reason is that babies just do great at 37 to 38 weeks. I mean, in an ideal world, sure, we'd let them maybe mature another week or 2, but they're going to do great. And that gets to the third thing, which is the risk of stillbirth that rises as you get further along in pregnancy. And while we wouldn't say that that's a high risk if you have a baby that's not anemic, again, if you're not as good at predicting anemia later in pregnancy, then, you know, weighing risks of prematurity, quote unquote, against risks of anemia and stillbirth, it clearly at 37 to 38 weeks tips over to where delivery is going to be recommended.
This is also another mom asked the question, it's pretty much the same question, but for being a low titer mom. So she has anti-E, too low to titer, and, you know, ACOG recommends delivery at 37 to 38 weeks for at-risk alloimmunized pregnancies. She says, is there any way to deliver spontaneously at term in her situation? And we were curious what you thought about that.
Yeah, that's to me, that's more controversial because exactly, I mean, if you've got that low of a titer, it's really unlikely that the baby's going to become anemic if you wait a week or 2. So really the risk of stillbirth or letting the baby get sick is minimal. I think in those cases, it's more a matter of, you know, laying out the risks and benefits of delivery at 37 versus 38 versus 39 versus even 40 weeks with the patient, and helping her make an informed decision about what is best for her and her baby.
All right, here's the next question from a patient. Can antibodies cause fetal hydrops or death if the MCA scan doesn't detect a high MOM?
Highly unlikely. MCA Dopplers, the first study that came out, really good study, was in 2000 by Giancarlo. I think it's Mare, I don't know exactly how to pronounce the last name, but that was kind of like landmark study that showed us how good MCA Dopplers were/are, and they're near 100% at detecting moderate to severe anemia. 100% is what most of us quote. Now they have false positive rates of about 12%, 10 to 12%. So there is the potential that we think the baby is anemic and the baby's not anemic. So the specificity isn't quite as good, but it's very good at telling us if the baby is moderately to severely anemic. And by that we mean a hemoglobin less than 10. A baby's not going to become hydropic at a hemoglobin of 8 or 9. A baby's going to become hydropic when we're getting below a hemoglobin of 5. So you definitely have a time period then where we would fully expect MCA Dopplers to tell us this baby is anemic. I say this all the time to my patients. The goal of MCAs is to tell us that the baby is anemic but not yet sick from anemia. That's the goal, because then we can intervene, not let that baby get sick, and optimize the outcomes. So MCAs are very good at telling us that the baby is anemic, and with doing them every week, it'd be exceedingly unlikely to get a baby that becomes hydropic. I mean, even if you have a false negative 1 week, you're going to be looking again the next week. And so it's very good screening.
Yeah. Okay. Good to know.
Particularly if you not just look at the number, but the trend.
Right, which is why the weekly scans are so important. Again,
This is a question for you, like human Dr. Markham. So not just Dr. Markham.
Okay.
What is something...
All the others were for I don't
Those
know
were
who-
not for.
Right, yeah. Not for a
But
human.
now I'm a human, not a robot.
Okay.
Okay, we
love
want to know, what is something that a patient did for you or said to you that made you feel so valued and appreciated, and like you have the right line of work?
I don't really need a patient to do or say anything. I just need a good, happy mom and baby. I mean, that's the truth of the matter. We're not in it for gifts. I'm not in it for applause or accolades. I will say that one patient gave me one of my most cherished possessions. She had a baby that was anemic, not due to hemolytic alloimmunization process. We never found the reason for the anemia, quite frankly, but we transfused her baby and her baby survived, and she drew this gorgeous set of drawings of a mother with her pregnancy, a mother with her baby, and put it in this just beautiful. I have it hanging up in my office. So that was very important, very sentimental, and had a lot of meaning to it. But in general, that was just the cherry on top of the sundae. I mean, the more important thing was that she brought her baby to a postpartum visit and got to see them both doing so well.
Oh, that's so
Amazing.
wonderful.
And that's why we
That-
do it. Mhm.
Oh,
Ugh.
it shows in your work and the way that you dedicate yourself to these patients and all your patients. But we know the version of you that is working with our patients, of course. But yeah.
Yeah.
It reminds me,
Wow.
Bethany, it reminds me of what you shared that you do for your living Allo baby's first birthday that I think you should share, because I just love it so much.
Yeah. Well, I realized that after I have the baby, I'm just overwhelmed with NICU and postpartum, and then it's best to just do a big thank you on their first birthday. And so with my 3 surviving babies, I have a large family, so all my siblings and grandparents and everybody, instead of buying my child a birthday present, I wanted them to write a letter to my MFM thanking them for my child's life. So thanking them for their nephew's life or their grandson's life, and then explaining what that meant to them and how they have enjoyed the past year of getting to know this tiny person. And then I just get all the letters together, and then I usually do a framed photo, and I send it to my MFM. And then I just like the idea of him seeing what an impact his work has on
Yep.
this entire community of people, not just the parents or that baby. I mean, you are impacting so many people, and it's just incredibly valuable work that all of you do.
That's
yeah.
amazing. That's so special.
Yeah.
Aww.
Okay. All right. So let's dive into our last discussion topic and question topic, which is IUTs and, intrauterine blood transfusions. So I have one patient question, and then we are going to read a few short patient stories and discuss, and then ask a couple more questions. Okay. So here's the first question. Is it true that obesity can make IUTs more difficult or more risky?
I wish it wasn't true, but it is definitely true. So we are taking a needle that is, similar in size to like a sewing needle, and we're directing that into an umbilical vein that is, if you're lucky, the size of a pencil. And we're not doing that in direct visualization. We're doing that under ultrasound guidance. And the biggest issue with obesity is that your ultrasound clarity is not as good because that adipose tissue just doesn't let you see as well. So it's definitely technically more difficult. And there are lots of things, not just obesity, that make procedures more difficult. Where the placenta is located, if it's in the back versus the front, it's going to be more difficult, earlier gestational age. And a lot of that relates to access to the umbilical vein, but also just how well you can see these things based on their size or their clarity. And then that obviously affects how well you can guide that needle down.
Right. Yeah, that's so interesting. I never thought of that with the ultrasound piece. Is the needle really as thin as a sewing needle? Almost?
Yeah. It's maybe a little thicker.
Wow.
Yeah. If you think about when you get blood drawn, that's a thicker needle than what we use for transfusions.
Wow. Really?
Yeah. Because usually that's an 18
incredible.
gauge, sometimes a 16 gauge, and we use 20 to 22 gauges.
Wow.
Wow.
The higher
That is
the number,
amazing.
the smaller
The
the
smaller.
diameter.
Yeah.
Yeah.
Wow. It's interesting because we talk about, or at least I've spoken with MFMs and other patients about, it depends on where your placenta is. It depends on where the cord insertion is and your gestation, but we never ever talk about the obesity piece, which I think is understandable because it's so sensitive, but then
Right.
is it, I don't know. Do the patients, is it good for them to know that? I don't know.
Yeah.
Yeah.
I mean, we still expect to be able to do what we need to do depending on body habitus, but it can be more difficult. And I mean, I don't know that it's not really something I talk to patients about because
Right.
it is a sensitive topic, but
Yeah. I'm thinking more of when patients ask us, I'm planning for a next pregnancy. Is there anything I
that's a
can
good
do
point.
to make that a safer pregnancy?
Yep, that absolutely can make it a safer pregnancy, or at least potentially.
Right. Or like less technically challenging, I guess.
Yeah.
Yeah. Okay. All right. Good to know. And now to wrap up, I'm just going to share a couple of answers that alloimmunized moms sent in to our prompt. And the prompt was, tell us the most memorable or shocking thing that ever happened to you during an IUT.
Okay.
Okay, so I'll just read two of these, and thank you to everyone who sent in their experiences. Okay, so this one is from Megan, and she says, my baby grabbed the needle with their hands, held it, and would not let go. The docs said they had never seen that before. The entire IUT was frustrating as they were having a very hard time transfusing any blood. This little moment made us all laugh since it was so ridiculous.
Yeah.
I've never heard of that. Have you heard of something like that?
Well, in the back of my mind, I'm thinking, why was that baby not paralyzed?
Yeah.
Honestly.
It was like the opposite of paralyzed. He's like holding on.
Yeah, they
That's
definitely.
incredible.
So when we do like genetic amniocentesis, for example, that's just putting a needle in the womb to get fluid and do genetics on it. With that, we don't paralyze the baby. There's no reason to. And so the babies definitely move and they'll run into the needle. And I've seen them like grab the needle before. But
That's
with
so
an
funny.
IUT, if you need to go into the amniotic cavity, meaning you're going into a free cord loop, the baby really should be paralyzed to make it as safe as possible.
Right. Yeah. I mean, they're active in there. They're active
Yeah,
little
they
guys.
are. Yeah, if you don't paralyze
Yeah.
them, they're active. And paralyzing them is fine. If you think about, this is something I tell my patients, if you paralyze me sitting right here and don't do anything for me, I will die because my diaphragm won't be working. I won't be able to breathe. If you paralyze a baby in utero, that's fine. The baby's not breathing. It's getting all its oxygen from mom. So it's just going to have a little lazy couple of hours and then pick back up where it started.
Wow. Can you imagine that transition for the baby who's like anemic and kind of maybe used to it a little bit, then goes from anemic to paralyzed, and then boom,
Bam.
it's like I'm
My
like
hemoglobin's 15.
alive.
Yeah.
I have so much power.
Yeah.
Oh my gosh.
It's
Like a
kids drink Red
superhero
Bull.
transformation. Yeah, it's like the Hulk emerges. Yeah.
Oh my god. I love it. Oh my gosh. Okay, here's Here's the other quick story about the craziest or most memorable thing that happened during an IUT. This is from Haley. She said, during several of my IUTs, Quinn would grab a hold of the umbilical cord, or one time she even kicked the needle right out. She would always be nowhere near the cord before the IUT, and the second the needle got put in, she'd be glued to where it was. My doctors laugh about it, saying they never met a baby that responded so well to getting blood.
Yeah.
I joke that right from the start, she's going places with her attitude.
Yeah.
So,
it's like a toy, I guess. I mean, if you're a baby, you're just hanging out in the dark.
Yeah,
Kind of boring.
nothing
Right.
All of a
interesting.
sudden,
Yeah.
there's like something to play with.
I was wondering, I wonder if Quinn is like very social, because she's like, oh, somebody's here. And then she
Yeah.
would go like,
Party
snuggle up.
time.
Yeah, that's kind of crazy.
I can share
Okay,
a funny anecdote.
Yeah,
Yes.
tell us about you.
Which is one time I was doing a transfusion. I had my needle. It was in a placenta in the front of the mom's abdomen, so I didn't even have to go into the amniotic cavity. I was right there in the umbilical vein giving the blood. And we rely on seeing the blood going through the umbilical vein. It streams through it. And there are a number of different things that can indicate that your needle has moved. So, for example, if all of a sudden it's not streaming, it's just kind of swirling around, that may tell us the baby's heartbeat is low. But oftentimes you'll see, if you come out of the vein, you'll see streaming. So you'll see the bleeding coming from that hole that you put in the vein. And that's okay. The platelets will take care of that. It will clot it off. It's not a big deal. But I got my needle perfectly positioned. I'm giving blood, and I see this streaming. I'm like, my fingers did not move. What is
Wow.
happening? And then I'm like, oh, that's the baby's penis. That baby's just peeing. We're
Oh
just
my
seeing a jet of urine that I can't tell the difference of
Oh
from a
my
jet
gosh.
of blood, but the baby was just peeing.
Oh my
Amazing.
Yeah.
that is so funny.
That's true.
Well,
I guess.
see, that
yeah.
I bet that baby was like well paralyzed, because he's just relaxed and letting it go.
Just
Yeah.
peeing. Mm-hmm.
Wow.
Yeah.
Wow.
I never thought about that.
Yeah,
Like
that was my
on
most memorable.
ultrasound, you can't like discern color on the ultrasound, so it's just a
No?
liquid in motion.
Liquid
Yeah.
emotion, that's right.
That's funny.
That's awesome.
Yeah, I was trying to think of the most memorable thing that happened during my IUTs, and the only one that comes to mind is just, so usually I would be wheeled in, and I have my hospital gown on, I'm wheeled in, and then usually I kind of hop up on the table. But I was like, I'm going to walk in, guys. This is unnecessary. This is silly. So I walk in, and there was a nurse in there who I'd never seen before. And she was just like, well, you have to be naked for the procedure. And then she just took off my gown. And right at that moment, my MFM, who at this point were like friends and kind of like working together, walks in from behind and just sees the cheeks.
The full Monty.
Sorry. Wait, no, just keep going.
The buttocks.
The butoxia is what my kids like to call it.
I like it.
He sees the full butoxia and just says, oh, wow, okay. And I was
Oh,
horrified.
yeah.
Like, when you are gigantically pregnant, also, that's not when you want somebody looking at your full butoxia. So that just came to mind, and then I thought, I'm just going to wheel in next time on the hospital bed and just, yeah.
Patients
amazing.
advocate to be able to keep your gown on. You can keep
Yeah,
your
there-
gown
no.
on. It's okay.
Yeah. No, though you could just pull it up.
Yep.
They can drape your
Exactly.
parts with a nice warm sheet, and you're good. So, yeah. I don't know how much of that we can keep in. We'll see what our producers
I hope
want to
we
do.
can keep it all in. That was lovely.
Okay.
One day I was about to get in the shower, and like I do try to shower privately, but my children always enter the bathroom. Like, they don't jump in the shower, but they do enter the bathroom to talk to me. And so one of my kids, I don't remember who it was at eye level with my waist, and I had just, gotten ready to shower, and he just like looked straight at me, eye level, and just goes, ew. That was it.
Oh.
I was like, oh.
They're humbling.
Yeah,
That's great.
that's it.
Oh my
Ew.
gosh. So funny. I love it.
Ew.
I love it. I love how we started and ended with kids stories.
There you
so
go. Exactly. It's what it's all about.
it
There we
started
go.
with Molly being like ew to your kid, and at
That's
the end
true.
the kid is like ew to
Full
you.
circle.
So it's
yeah,
a
ew
full
right
circle
on
moment
back.
here.
Yep.
Go.
Yeah.
Well, I guess we can end with that.
Yeah. Thank you so
Goodest
much
place is
for
Eddie.
Yeah.
being here with us. I apologize again about not telling you that you will be on camera.
That's okay. I apologize
I'm
for my dog barking.
That's
They
fine.
were pretty good overall.
They
Oh,
did
yeah.
do a good job. At least they stopped death
Oh, no,
panting.
they did not stop death panting.
Oh.
It's just that I'm in a room where you can't hear it.
Okay.
I guarantee
Oh my
it's still
gosh.
happening.
Oh, I'm so sorry.
Oh my god.
Oh my goodness. All right. Okay, Molly, who's gonna end it? You?
Oh, I don't know.
Not end. Well, okay. Who's gonna finish out the after the death, and then all right, the death
Okay.
breathing, and then the ending it.
I'll just add,
Molly.
though, for clarification, my dog's not, well, I mean, he's 16. He's not
He's
spry,
fine.
but he's fine.
I'm sorry. Yeah.
Yeah.
Yes.
It sounds
Life
bad,
ra-
though. It
The
does.
life rattle.
The life rattle, exactly.
Okay.
We'll call it that.
All right, Molly.
Oh, okay. How do I just go right
All
into
right,
it?
Molly. Do you want to? I don't know.
Took a weird
Okay.
turn.
Yeah.
Okay, I'll just try our usual sign off. Like it's
Okay.
a totally normal transition. Okay, here we go.
Okay.
All right. Whether you're a patient, provider, or otherwise affected by antibodies in pregnancy, we are here for you. We have great resources on our website at allohopefoundation.org. That's Allo, spelled ALLO, hopefoundation.org.
Thanks for listening.
Thanks, everyone.